Great. Thank you, Mr. Chairman, and thanks to all the witnesses. I want to start with the surveillance issue. We talked a lot this morning already about CDC, but what happened? Why didn't the CDC have the ability through the surveillance systems that we had in place to be able to detect this sooner? Seems to me they were relying on incomplete and outdated public health information, among other things, as I said in my opening. Some of you have talked today about the need for digital monitoring and that there were early warning signals that were not picked up. Dr. Gerberding, you focused on that. What sort of surveillance indicators was the CDC relying on at the outset of the pandemic to inform the public health response?
I think first and foremost was to take a look at what was going on globally. We had some information about the extent of spread in the Wuhan province. We had examples of pretty well documented spread from travelers into work settings in other parts of the world. I think the clues were there that this was a very transmissible infection, unlike SARS was in 2003. So that was the first thing, is to lean into the threat that exists. The second thing is testing. And, I think it was unlikely, even under the most rehearsed scenario, that we would have been able to immediately deploy a test for a brand new pathogen to 300 million people on short order. But we certainly could have utilized the tests that were available elsewhere in the world and had proven to be useful. And we could have worked much faster to bring the scale of testing up to speed with better cooperation and earlier engagement of the academic sector as well as the private sector. So the first thing that needs to happen is case detection, and then the isolation of the cases, the quarantine of their contacts. Now, that's a problem in the United States because finding contacts is basically shoe leather right now. It means you have to go out and more or less door to door track down the people who might have been exposed. And our workforce is way too thin to have been able to accomplish that once we had so many cases. It became almost impossible. I think a third piece of this is to use our epidemiologic common sense and recognize that with a respiratory pathogen, there are going to be certain congregate settings, confinement, high degrees of contact, where there is likely to be transmission. And to get into those settings first, do the testing and the epidemiologic assessment so we're ahead of the curve rather than waiting until cases were hospitalized and then find the hot spots in retrospect. So a lot of things are a combination of testing, workforce scarcity, and I think, again, just the inability up front to imagine how bad it was going to be.
Yeah, I'd like to dig a little deeper on the testing with you and Dr. Lurie and anybody else who wants to jump in, but backing up on surveillance for a moment, because it's not just about testing. As you indicate, it's also about the World Health Organization telling us what was going on, which they did not. China being more transparent, we know that. But what type of fixes do you think we need to make beyond additional funding, which I appreciate, and I appreciate the fact that you said that personnel are interesting, are needed. You mentioned, for instance, using technology better in your testimony and digitizing some of this. Just quickly, if you could, what could we do on the surveillance system in addition to testing to make it more effective?
Well, one really important point that I think is implied in your question is that this is a global challenge.
Mm-hmm.
And if we had really actualized the promise of the global health security agenda, we would have had much better insight into where this disease started and how fast it was spreading internationally. So we do need to come back to that global network of surveillance, not just a US network. In the US, I agree with you on the digital tools and the application of our technology in new and exciting ways. But at the end of the day, it boils down to case detection as the first step.
Yeah, well, let's talk about testing for a second. And again, anybody who's free to jump in here. I'll tell you my frustration on testing was that CDC, and some of you have been involved in CDC over the years, and there's plenty of blame to go around here, but CDC had lousy tests. And, in Ohio, we were given a bunch of CDC tests, and that was the only place to get tests, as we understood it. And, they didn't work. There were defects in them. And it prevented our labs from being able to validate the tests, rendering them basically useless. I don't know if you know this, but in Ohio, the result of this was that some of the private sector jumped in, and particularly the Cleveland Clinic developed its own test. And give you some dates here. We got our first, our botch tests from CDC on February 7th. We didn't get a working test kit from CDC until March 5th. So virtually a month went by, and talk about, you know, a waste and an opportunity to save lives. And the Cleveland Clinic developed their own test and put it online on March 13th. That test I took, by the way, early on. But why were we so reliant on CDC? Shouldn't we have been encouraging the private sector to be involved all along? And again, Dr. Lurie, to jump in here, how did the legal and regulatory landscape at the time help or hinder institutions like the clinic, to use them as an example? But there are groups all over the country doing this, from developing their own tests. Could you respond to that, Dr. Lurie?
Yeah, sure. So what I would say is early on, when it was clear very early on that we're going to need an awful lot of tests, and tests were developed around the world, as Dr. Gerberding said, some of them worked quite well and we could have used them. And when CDC was struggling with its test, or even before, BARDA should have exercised its authorities and gotten in early on to stimulate the development of diagnostic tests across the private sector and in the academic sector, so that you would have had a variety of tests earlier. There was no entity that took responsibility for pulling samples together to validate diagnostic tests. And so all of the test developers really struggled. And so FDA gave an awful lot of them a pass and said, well, you're not going to need an EUA. We're going to go ahead and assume things, assume a number of things. And then it turned out that we had diagnostic tests that didn't perform well at all and had to come back off the market. So the failure to get in early, ask the private sector to develop tests, agree to work with them, provide the support that they would need for validation, and then be able to scale, I think were really significant failures stemming from the failure to want to recognize that this was happening. The authorities were clearly there.
We've got to learn from that clearly. And, it just amazes me that we were so ill prepared in terms of our diagnostics. My time is coming to an end. Admiral Nimitz, I'd planned to ask you some questions about the Benz Commission. I appreciate the work on that. Senator Hassan was involved, who's on the panel today, Senator Cassidy, but we really have appreciated that, and we're using some of your work. I guess the planning and the exercises, were not adequate in this case. And one question I want to just leave with you as I end my time is FEMA the right organization to head up something like this? There's a difference of opinion as whether it should have been HHS or FEMA, and was FEMA the right entity? So I'll sort of leave that question out there, hoping somebody else follows up on it who has more time available. And thank you, Mr. Chairman.